Awesome. Today is Friday. Glad we're having a really, hopefully a very interesting code blue. No one has to go to the ER or whatever, but we're really going to have a great conversation today. Why you need to go from the get-go with clinicians in a startup and what might not go right if you don't. So let's have our guests. Really glad you're here. Drew, you want to introduce yourself, start, and each of you just really quickly introduce yourself before we get going on this. So glad you're here, guys.
Yeah, thanks, Michael. So Drew Lundquist, I'm a podiatrist by training, chief medical officer for the Mankato Clinic, and then I have a role at Nabla as a clinical director, just trying to guide the clinical side of that. Really glad to be here.
Awesome. And then Brendan.
Hey, Brendan Keeler. I'm the interoperability practice lead at H2D Health. I've worked in EHR and interoperability my entire career, and I write Health API Guy on the side. It's a Substack about healthcare and interoperability.
Awesome. All right, Adam, please go ahead and introduce yourself.
Yeah, hey, Adam Glassifer. I'm a pediatric hospitalist by trade, but exclusively did pediatric ER for years. Now I'm the founder principal of Vertex Health, which is a boutique consulting advisory firm, leveraging my experiences working as a clinician in a health system at Amazon to help enterprises build large innovation programs and to help startups scale. So thanks for having me.
Well, man, I am glad we got some perspective here today. And where do we start with this? Like, what is the good, the bad, and the ugly when doing startups and you think you can go alone without a clinician or an interoperability specialist? Where do we start, guys?
I mean, I think you could start with clinician input early. You know, the title of this, clinician-led startups, often those startups, the clinicians are not the best leaders or CEOs of startups, but it's critical to have them on board from day one, because there's plenty of times that I've seen companies pitch a solution to me and it's clear, I watch it, I'm like, nobody's going to use it that way. That's not going to fit in a clinical workflow. So having that early, it will definitely save a lot of steps.
And I imagine you're not talking rocket science, like just go out and ask a few of them, right? We're talking just an early discovery, like, would you use this? Like, what would that look like?
I mean, it is not rocket science, right? Find out who, this really goes for any product. Find out who your user is, your customer, and work backwards from them. It's like very, very basic, but often overlooked. People think of an idea and it's going to be the greatest thing ever and change everything. And they sometimes skip that step of how it's actually going to be used in the real world. So yeah, do some voice of the customer, user research.
I would say it's really like the reason that happens in healthcare as a vertical is because the empathy gap for someone who is not a clinician is much higher than building a consumer app or building a horizontal B2B application. Like, we go to the doctor as a non-provider. You go to the doctor and your experience as a patient is one that you over-index on when you're creating products. So people say, oh, I'm going to create a personal health record, or I'm going to, they think about the patient experience, which is important, and like you can create products there. But if you're selling to providers and provider organizations, that's sort of not the empathy that you need. You need the user empathy and understanding of providers as users or provider organizations as buyers. And so, yeah, I think it's just that empathy gap, because as a verticalized industry, you couldn't be further from really understanding the minutia of like cardiology or podiatry or whatever when you have never studied those things. And so that's why, people come to me and they say, oh, I just need to get integrate with the HRs and my product will sell, and their value proposition to providers or to provider organizations sucks. And they haven't done part one. And I say, don't talk to us. Don't spend money with our consultancy, because you need to go figure out how your product is actually valuable to a provider organization first.
Yeah, I love being on the show because it's super self-serving as a clinician talking about why we should be, right, Adam? I mean, I think let's go, right? Everybody needs one or two. But as a chief medical officer, putting that hat on, in prepping for this, I looked back at a number of the groups that we were talking to and trying to see, they had a really cool tool, but then it just didn't quite work. And I went back and I looked, and a lot of those groups didn't really have strong or any clinician input into their team. And so it just didn't quite fit. And really, we talk about the workflow in healthcare, really how that work gets done in a practice. If you mess that up, you may have a great idea on the patient side, Brendan, what you were talking about. But if you mess up that workflow for the clinician, they won't even touch you. And clinicians are awesome at just quietly quitting. Like, they'll look at it and then they just won't use it and they won't tell you about it. They just go back to their old workflow.
I'm going to be, it's never good when we're all agreeing. So I'm going to posit something that sort of like pushes that. Yes, it is like the reasons we're saying it's awesome to have a clinician on staff or like for reference or to do customer interviews, like whatever your path is to have empathy. But especially with larger healthcare organizations, you can also have the wrong empathy in the sense that like something that physicians say is good or useful or whatever isn't the buyer. It's the principal agent problem, right? That the buyer for, the mega corporate, the mega IDN is the CMIO, the CEO, the CRO, like the executives that need to see ROI and like entirely different metrics. So having empathy for clinicians as users, but also empathy for the problems of the decision makers that are going to get your project prioritized is another lens that you need to make sure that if you're hiring Drew, or if you're hiring any clinician to be this advisor, they have to have that lens in their brain too, which many clinicians do, but not always, right? They may over-index on their own problems and build something that's really cool for physicians, but won't be able to sell into large enterprises because of the user and decision-making divide.
I've totally seen that happen too. And I just want to go back to a couple of things Drew and Brendan said that are key. Aside from clinicians, there are two other major stakeholder groups, right? The patients have to interview the patients and factor them into decisions. And then the one other, if you're selling into a health system, having spent many years as an associate CMIO in a health system, you have to also factor in what's the implementation look like, because that is key. Make it as easy as possible. Just because it's a good solution, if it's a complicated deployment, you're going to be very low on the list. That's going to take a lot of effort and take a back seat to other things that are far, far higher priority.
And that's why we're self-serving over here, because who helps with that? It's HTD. Right. But yeah, like they are weighing what is the value of your solution, the value proposition to the provider, to the executives versus the cost. And the cost that people think of is the dollars associated with it, but the actual cost, the implementation cost, the opportunity cost of doing a 6-month implementation for this complex product. Those are the other things that are being weighed on the scales. And so you have to minimize your implementation costs, or at least give them the perception of minimizing what that looks like. Or they're going to say, well, I have something that's way more valuable and is 2 weeks to set up. And they're going to do that every single time.
Yeah. And the implementation cost to us on the clinic side is often just time and effort, right? You just don't forget about the IT builds that have to happen, or what's on IT's plate, or what time of the year it is. Is your IT team and quality team looking at, submissions for payers on closing gaps at the end of the year? Like, you're not going to get anything through us at that time. You have to be pretty careful on time and effort that you push out to IT. Never forget them, or quality or data, right?
Yeah, Michael, you're going to ask like one question and we're just going to keep going through. But the other thing is also often the IT thing is in, but then they don't think about the education, the change management, the, informatics support, like all of those other things factor in. So key stakeholder buy-in and getting their voice early on is critical. Something I always work with startups.
So what do we want to? Would we like to talk a little more? I kind of like the term data chaos as something that could happen if it's not done right. Brennan, do you want to talk a little bit about that in your experience? I mean, you're trying to organize this and around Otherwise you get chaos.
What I'll say is, if you have a strong value proposition, you have this clinician leader, you've navigated the value proposition maze, you come up with a workflow, and you're talking and you're saying the physician needs to do this or other users needs to do that, and the data flow to accomplish that is what both the minimum viable data flow to just get something live quickly to the point we were just making, that's really important to minimize implementation cost, as well as your ideal data flow. Like, that's integration, that's EHR integration, and designing that and creating that glide path from let's just get live and get users using this, and there'll be some workflow sacrifice to we're providing 10x value. That's a big challenge, because every application that's being built for providers is different. And so I think once you've figured out the value proposition, once you've figured out the workflow to accomplish those value proposition, you got to create that glide path and then map it to the diaspora, the incredible complexity of integration methods we see across EHRs, right? Like, there is not, even with standards, even with the regulatory pathways that have been put in place to standardize across EHRs, you see a ton. You'll see a ton of different inputs and outputs. You have to do standards like HL7 FHIR. You have to do, screen scraping and direct to database, flat files. And so that's really, really complex, but that is the how. That is the gutty, hard work that you have to do to accomplish the workflow, to accomplish the value proposition that makes providers and other users delighted.
So how are you bringing that clinician in that process?
I mean, we talked about a few strategies, right? Like, one is just to have one on board, and you can just say, is this right? Is this right? Is this right? This is how you think about it. And you're relying on their empathy to be broad enough, if they're doing podiatry, like, can they think in terms of cardiology or whatever? Like, it depends on the empathy gap that they have. But, just talking to end users, as Adam was saying, is how product management is done. And so, like, you can't go build in the ivory tower your product. You have to go and talk and say, does this look good? Does this solve a problem? Is this valuable to you? Like, those are standard product management tactics that apply here, and just are harder because we can't just innately use our own intuition if we're not a provider.
Go ahead, Adam.
No, I was going to just build off of that. And, the other thing is, Brendan talked about workflows, but it really is key. A lot of times you'll hear, startups or other companies say, well, they'll log into this other portal and then they'll get it. And that's not going to happen. So, you're getting all of this data and it's valuable, but you have to put it into the clinician workflow. So typically that is through integration into the EHR. I mean, there are different creative ways you can do that, but again, unless it's in the clinician's face and in their workflow, it's just not going to be valuable, and it's not going to be used.
Unless they're super motivated, right? It's always interesting to see. You have some, at least in my multi-specialty group, I have some who will take the extra time to go find the extra tool and make it work. And then I have the majority who I might go do it if the wind's blowing the right day, and then there's a few like, heck no, I won't do that. Right. So it depends on the motivation of the clinician, and you almost have to solve for 70% of workflows out there, which is why you need to talk to a number of practices if you're trying to put a workflow in, because it might work great for psychology, psychiatry, but urology is going to not want to use that. So really you have to get a good wide swath, a wide biopsy of a practice before you put something in.
I think there's one benefit potentially of, like, the clinician-led or the clinician hire is, you short circuit the networking piece potentially if they're well networked, and like, doctors know other doctors, and they can say, okay, I don't know urology, but I know somebody who's a urologist, much more easily than the plebeian like me. Although I know I come from a long series of urologists, so that one in particular I can just go up the chain.
He'll be our go-to. So.
Is there, in your experience, have you been blown away? I don't want to get into like a specific product or feature or company as clinicians that you're like, wow, this is really amazing, or anything on the other hand, like this was crap and they didn't do that. Is there any sort of examples that you have been blown away with in your experience with product?
You know, I can give one from my hospital days. It was probably every step of the way. It was a very easy to understand ROI. It very easily solved the problem. The connections were done with all stakeholders. And at the end of the day, it was actually kind of a basic solution. It was telesitting. So it was basically replacing these high cost individuals, humans that had to sit outside a room for these kind of medium risk patients that needed, you know, a set of eyes on them. And what this system's able to do is basically, you know, take a camera in each room, and then you have one person in a control room who's able to then manage 16 patients. And they really had it covered, you know, front to back. You know, the ROI was there, the deployment was quite easy, the education was quite easy. The necessary data flowed where it needed to. So it was really well done. It's something I often refer to when I'm doing some of my work and just really crafting a simplistic, linear, logical case for a solution that connects with a very clear ROI.
So just a question on that, Adam. Did they, when they implemented or when they trialed or piloted, whatever you did they have people elbow to elbow with your group? Were they virtual? Like how important was the touch?
So initially there was some feet on the ground to train the people that were going to be in those control rooms and some education. So, and it's a great point, because when the vendor or company can provide that resource, right? If there's less of a technical build on the inside, that's huge, because then you can actually support the existing staff. When it's really reliant internally, right, on both technical and human resources for deployment, it's kind of when it gets a little bit more messy. And for some solutions, the external, you know, vendor team, consultants providing that hands-on support, sometimes it doesn't work as well as when you have the internal teams. I mean, I'm sure you've seen this in your clinic. Sometimes it doesn't work as well, but for this one, it was pretty ideal.
Yeah, I'll say I bring that up just because our clinic's 180 clinicians, 800 employees, and everyone has a day job, right? And so you want to implement these tools, you want to take it to the future of where we're going, but we don't have a full FTE. So if the company can give us someone on the ground for a little while to kind of train the trainer type thing, that really helps us get to the next level. Because as much as we want to do things virtually, as much as we want to do those kind of trainings, if you can have someone really like, okay, hey, clinician, I'm going to sit next to you and we're going to go through the implementation. We're going to show you how to do it going forward. You can really get to those problems. So my clinic uses Nabla as an AI scribe, and we implemented it, rolled out, worked really well for a lot of clinicians. But my allergist, he gave me a call. He's like, "What are all these notes with marijuana allergy on them?" And I'm like, I don't know how that happened. So we went back to the workflow working with Nabla, and they're like, "Oh, weed pollen allergy," which is something big in the Midwest, weed pollen. And it took the slang for weed and made it marijuana allergy. And then we chuckled at that, but they quickly, within, an hour, changed that on the algorithm, right? If you don't have that really close touch, a clinician like that might just say, "I'm done," because it's putting weird things into my note, I'm done. But if you have someone who can quickly do it, oh, it's kind of funny, we move on, right?
Unless you're in Portland, Oregon like me, and then weed pollen was correct the first time around.
Right.
But no, I think it's not unique to physicians or physician organizations. Even tech organizations can be graphed on like how tech enabled are you? How much do you invest into your internal operations where you have IT staff and things like that? And if you think about that across any organizational type, this applies, where if you're selling a product, you have to decide as part of your sales tactic, what is this? How white glove are you going? Because, or how self-service and tech enabled are you focused? Because what you invest in from a product capability of, do I build an API or do I use that spend on an implementation staff who goes boots on the ground? And your choices there dictate, do you sell to traditional varieties of an organization or tech enabled varieties, right? Like if you build an AI scribe and you say, I'm going to have APIs, you're saying, okay, I'm building for very tech forward builders. And if I say, you know what, I'm going to have 4 implementation staff to go to Doc Smith, who barely was able to adopt an EHR, you know, those are separate choices. And over time, you can do both. But as a startup or young company, you do have to choose where you're starting, because you can't do everything all at once. And so that applies especially for providers. But I know I've worked in tech, and I've worked in tech companies they have tons of operational stuff, and we adopt new tools, and also ones where it's just so painful to even get a report of how we're doing. And so, I think it's a universal principle that needs to be thought about as you build for other organizations.
Well, what would be the play? Adam, I know you do a lot of consulting with startups. I mean, if there was a playbook that you could recommend, obviously you can't do it on this sort of short time on the show, but what would be the right way to do this from the get-go?
In terms of what? Just a smooth implementation, or?
I guess I mean, obviously we can't boil it down to an algorithm, but like implementation, if there was certain rules, principles to mitigating risk to getting it wrong. If you were implementing, what do you think are these principles, if there are first principles to try to get a product right? I mean, Brendan brought up a good point. You got to make choices. You can't do, but so much. But are there some first principles where you can try to get it right more than wrong?
Yeah, I mean, and I think it goes back to a lot of what we've discussed already. But when I often engage at various points of a startup's life. When I'm there early, I typically am really digging in on the stakeholder piece and keeping it simple. Those are kind of my big tenets for companies. And when I say keep it simple, on every level, like we said, from an implementation standpoint, from a tech standpoint, from a ROI standpoint, like making it all very clear. And so a great example, one company that I work with very early on, they were developing a solution on identity, and they had all this hardware built into it. And having deployed solutions like that, I was like, guys, let's get rid of the hardware if we can. Like that you've just added such a level of complexity for an organization to maintain those devices, to integrate those devices, to train on those devices. And to their credit, they were able to build an elegant solution around that early on, as opposed to some companies, if they don't have that level of foresight or the right people involved early on, they may have deployed and then learned that the hard way. All of a sudden, their kind of implementation plan is a very, very heavy truck roll. There's all sorts of hardware, and they are suddenly buried in maintenance that they hadn't anticipated, that isn't even the core part of their technology. So I think it's really just keep it simple, listen to your customers, listen to your stakeholders.
I'll add to that, just that you have to have a clear path. You said simple, a clear path to solving a problem and then having an ROI, right? So a lot of times it can be a great idea. It can be the CMIO is on board, the CMO is on board. All the clinicians are like, yeah, this is a great idea. CFO, CEO side is saying, okay, is there a direct ROI? Because right now we can't do that unless we're either taking up a line item, like for like, if we already have it in our budget, like let's push that to a different vendor or a different solution, or is it going to actually increase our revenue on the cost of care or directly on increased patient visits? So when you say simple, to me, my mind goes to, okay, is it clinician friendly if it's clinician patient facing? And then is there a direct ROI? Because if that ROI is not clear, it's going to be really hard to get that down the road. And I don't know, Adam and Brendan, if you see that on your side, how important that ROI component is.
Yeah, it's critical. Yeah.
The empathy for an organization, right? Like organizations want to delight their employees, for sure. That is one prerogative. But at the end of the day, their metrics are not usability and things like that. It's about ROI. It's about making the business more successful. And so the leaders of, especially like as you go up from SMBs, like single doc practices, up to enterprises, that becomes more and more important, for sure. You can convince a single doc practice to use or adopt technology because they'll be more efficient or they'll be happier, solely on the merits of that with no ROI. But as you go up to enterprise, that becomes less and less, or almost a non-existent metric, unfortunately.
And I actually want to go back to something Drew said, because it seems so obvious, but it gets missed a lot. Solve a problem that's actually a problem. So sometimes, it always surprises me. There are these solutions that are built, and they go to, kind of pitch it or start to socialize it, and they're sometimes pretty far along. And then they find out it's not actually a problem that anyone needed solved, or it's a problem that really has no financial implications, which, it's never going to go anywhere. So make sure you're solving a real problem, not just a problem that you perceive exists.
Yeah. And something I just put on LinkedIn about this, because I see it all the time, is like, if there's a problem for an area, like a geography, that doesn't mean it translates to another area. I mean, medicine is very geographical. There's areas where there's big systems, the enterprises, and then there's a lot of areas where there's a lot of single doc practices, and it's really run by a bunch of little groups. So you can solve problems for one area, think you're going to take it to another area, and that problem doesn't actually exist in that geography or in that workflow or in that system. So it's so important to get a snapshot across really what is a really weird ecosystem of healthcare in this country.
Or you specifically say, I'm going to go solve this for home health, or I'm going to go solve this for, podiatry, PT, like whatever, because it is, as a vertical, 100 fragmented fractal subverticals. Like that's the reality of almost any vertical, but especially in healthcare, where the specialization of practitioners and care means that a home health workflow where somebody's going to, go document OASIS forms at somebody's house is completely different than an outpatient visit, is completely different than an inpatient visit. And so imagining tools or creating tools that scale across all those scenarios isn't a reality. Like actually, the markets are much smaller and more focused, which perhaps means that there's less venture backability, but more bootstrapping for really specific niche things, but great businesses to be built all the same.
And that speaks to so taking home health as an example, in an area where there's a lot of integrated vertical organizations, they put in the order for home health and it stays internal and they work their way to an external vendor, right? But in an area like Florida, where it's a little more segmented and there's smaller practices, then go to other practices, you just have to you can have the same product, but you have to have totally different workflows to get from that home health consult to the external vendor. And that's something that I see often, is that, I'll have someone trying to sell me a tool that doesn't, I see the problem, but in my geography, in my system, that problem doesn't even exist. So you shouldn't even be trying to sell to me. You should be somewhere else.
What are you seeing right now in the landscape with opportunities in healthcare? Are there is there anything exciting? I mean, I hate to use AI, but what are you seeing right now out there that, like, we had a show. I had no idea there was so many EMRs There's still a lot of EMRs, but of course there's a ton of AI companies. But where do you see areas of opportunity? Any of you?
I mean, I'm happy to start on it. So when I was working at AWS, we used to run this exercise before we ran our accelerator programs there. And we would talk to C-suite leaders around the world and ask a standardized set of questions just to get an idea of, what should we focus on? And I think the most important question we always asked was, what do you have organizational buy-in, and what's the biggest problem that you have organizational buy-in to solve, money to buy, and people to implement? And what we found was that the answer was actually the same a couple years in a row. It was anything that helps our workforce and the looming workforce issue. And I honestly don't think that's changed much. And and if you think about a lot of what we've talked about here today is kind of smoothing those workflows, making it easier. I mean, that is part of the workforce. But anything that makes the complex, delivery of clinical care, and I'm talking, back office, I'm talking procurement, I'm talking, any aspect of it that makes those things easier, you can probably craft a pretty solid ROI that's going to compel health systems. And there are lots of interesting solutions in that space. I mean, we hear about AI scribes, which, I think they're great when done right and implemented right. So, I mean, that's a major, if the gain can outweigh the pain, you'll get buy-in every time. But I think that's a major space that's not going to go away for a while.
Yeah, I think I talk about this a lot, but like you have these two categories, right? You have AI copilots and AI agents that are like the hot things, and scribes, shout out Napla, are very popular because they are easy, right? Like don't change the workflow that much, just passive listening, it's ambient. All right, and then the outcome is distinctly user happiness, so great, and potentially ROI, TBD, but strong signs there. And so the adoption is really easy, and the VC money is flowing to those, and they are, like providers are psyched. I do wonder if, to our points earlier, is like if the primary value proposition is less pajama time and happier physicians, is that the outcome that organizations need for the cost of these things? Whereas AI agents, quite scary in the fullest sense, but have clear ROI. Right?
Mm-hmm.
Like you can potentially scale your organization at fractional costs. You can potentially repurpose jobs and focus on higher acuity problems. And so while there's significant social and legal and barriers and fear, uncertainty, and doubt ahead of us with the agent side of things, those are much cleaner fits for the things we talked about in terms of clear ROI, something that the value accrues to the organization and not to the end user. Because when the value accrues to the end user, the provider or someone else, it can be lossy. Maybe the doctor doesn't refunnel that time that was spent doing notes and doing pajama time back into work, but instead just takes time to hang with their daughter. And so there's a lossiness that doesn't translate as cleanly into the ROI narrative. I'm generally optimistic. I think it's slam dunk that these co-pilots are going to supercharge and make providers 10x better. But if agents are 100x better or 100x margin, we're going to see pretty quick adoption as those become more mature.
Yeah, it seems like with co-pilots and with scribes, what we've seen more trust in the scary AI. That when we talked about it with clinicians a year and a half ago, everyone's question was, but is it safe? Is it going to, is Big Brother listening and they're going to steal my data, right? We're way past that. There's trust now in the workflows and what it's doing. And now getting to that AI agent side of things, that's where there probably is a more direct ROI because you have an agent doing a job. But I think that trust factor now in most healthcare organizations across, I think, America is that we don't necessarily trust that, okay, we hire or turn on this tool that we're purchasing for quite a bit of money up front. Is it actually going to do and have that ROI of taking that role that we're currently paying someone for? So to me, I see a bit of a trust gap right now that we're going to have to bridge here in the next year or two. And that's, to me, that's the other thing. Interesting to hear what you guys think on this.
Totally. Like that's it. Like there's the trust gap because there's liability, there's risk, but organizations that are greedy, and so like at some point they will say, "Oh shit! Like I can make a ton of money, and I pursuing it for X, Y, or Z use case in regards to agents," because as soon as they see the tipping point and that they can do some role, maybe it's behavioral health in a certain segment, or maybe it's like a very niche piece of it, but they can carve that out and provide and scale behavioral health almost indefinitely, then wow, they're going to run for that opportunity. And so, yeah, the trust piece, the licensure piece, as we get into like the hairy, sticky things of like prescribing and those sorts of things, there's some real social barriers that we'll have to grapple with about where the line is. But there is this incentive that's baked into it that the promise of it is, Kaiser Permanente can scale nationwide or something like that. That's the upside for these orgs. And I think some of them will be drawn to it like a moth to the flame.
Any areas like, it seems like caregiving with technology, not robotics, full bipedal like robots, but it seems at some point for certain tasks, whether it be medication, whether it be sensors in the home, organizations, are doing these things, but I don't know why Japan and other countries are more open to that. I know we're getting a little out there, but it seems that, it's so much to take care of aging adults if there's more reliance on certain tasks.
I think well, go ahead.
Go ahead, Brendan.
I think robotics are rad, and I think it's like a logical, like we've seen, just surgical robotics in the past couple decades be really useful. And if you start to apply AI and some of the things there too, like you can imagine some like real high tech, cool future outcomes. I personally, I'm very bullish and optimistic on all this stuff. I'd feel a little hesitancy going under the knife with, an AI robot doing it today. I think that's my trust line. But I think if you start to think ahead to those futures of specialized robotics and, the hardware element on top of this compute layer that AI offers, the flexible compute layer, oh boy, we're going to have some real cool stuff ahead.
Well, and having that human in the loop, right? I think we need to talk about a patient, clinician, AI agent. Like there's another entity in the room now. And so the more that you can lean on that, whether it's guiding your thoughts on a differential diagnosis, which we know, there are studies that clearly show that it can do it more quickly and more reliably than most clinicians. Most clinicians don't like to hear that, but it's true, right? So we need to have kind of the thought process of, okay, we have the patient and the clinician and that third agent, whatever they're doing, whether they're guiding your knife to go here, not here, but you need to do it. We need to lean into that more. And it seems like the organizations that can help to really empower that and can get the organizations on the clinical side to trust that third agent and then implement that all the way across. I mean, every nurse is going to have an agent that's going to help them. Every, billing, coding person, like all of those should be using this. So how do we lean more to that, and how do we enable that thought process? And that's for our organization, that's a big jump. I mean, I know many people are using ChatGPT, whether it's on their phone or their computer, but are they using it in every way that us as an organization can be more efficient? Probably not. And that's where we need to get to.
And I find, I'll go back to the robotics piece. I'm bullish too, by the way. I find whenever integrating new or emerging technologies into clinical care workflows, at least my experience, the best way is to kind of start at the peripheries of clinical care. So, Drew was talking about nurses, right? That's a great example. So how can robotics take off some of those non-value added tasks? And the reason I, dig into nurses, so I'm married to a nurse. I'm always very sensitive to nurse issues. And a lot of times when there's some other task that needs to get done, it comes up, oh, well, the nurse will do that. The nurse will do that, right? And realistically, nurses are skilled, trained professionals that deliver care. So that's a great entry point for robotics. How can a robot take some of those tasks that like really a nurse shouldn't be doing because it's not the greatest use of their time and they're busy. And those are ways, once people start to see things like that, it then sparks, they're like, oh, well, a robot's delivering linens, right? There's no risk in that, right? Or low risk. I'm sure risk management could point out 10 ways that's risky, but it's low risk, right? So you start to do things like that and they become value added and people start to kind of think of these new ways, even though, the four of us can be like, yeah, why wouldn't a robot do surgery? It takes a path, and that's a great entry point. I mean, I'd love to see more of that. There are examples, some health systems do have delivery robots. There are, pharmacy robots that I know deliver, but I'd love to see more of that.
Well, and it's the gateway drug, right? It's kind of like the Mountain Dew, right? You got to find the easy solution that people are going to want to use, right? And so I think we saw that with AI scribes, and it's relatively simple. It's easy to use. It just rolls. And now people are asking questions. Well, can this scribe also give me the right diagnosis and the right code and help to put my bill out for me? It's like, yes, we can. Just wait. We'll get there. So you said earlier, Adam, to start simple, and it's like find those simple problems, those workflows that you can kind of get your agent in there, and then you can go from there. But you have to enable that thought process of, hey, we're not just doing this, we're going here. And that's the exciting point, I think, of healthcare right now, is that there's a lot of opportunities.
Yeah, I think we all one day will sooner than later have our R2D2s. I mean, it's just a matter of time. So I want everyone to know I want mine. I'm not like the price point is not there yet, but we will see them in the near future. And a nurse should have the R2D2 to get all the whatever so that they can be hands-on delivering care. And we will see it sometime. And it's a design challenge. I mean, those organizations that can figure out how to embed it in the care and do it and will win. It's so anyway.
I'm ready for my R2D2 also, for whatever that is.
But for you, Drew, with podiatry, where would you see low areas or opportunity for implementation of some of these technologies?
Yeah, I'll push that out to organization wide. At our clinic, we're a multi-specialty group, and we see really opportunities as we're looking at our organization. Not so much. I mean, we're looking at the clinical side, of course, and all the things we've talked about, but even on the back office, my HR department, they have to answer a ton of questions. There should be an AI agent that is hey, when are our holidays, or how much PTO do I have left? Simple things like that just take up a ton of people's time. I think as an organization, we really have to look internally and look across each department. What's taking up the most time? Because right now we know there are probably a couple of agents that can be easily doing, 50% of the work that's going on out there. And so, I think we need to look a little bit more of a wider lens across healthcare organizations, because a lot of times I like to focus on, the healthcare component, like what's happening there. And we certainly are doing that. But I think taking up that 50%, where's 50% of the work going, and how can we make that easier so you can do the other stuff?
And actually, I love that example too, because it goes back to the earlier point. So HR, that's a great place to integrate an AI agent. So sometimes, for example, you're not going to just throw it into RevCycle, right? That's way too risky to do initially. I know there are some that do it, but you kind of build from there. And I mean that's a great one.
It's funny because I see people throwing stuff right in the rev cycle.
I know.
Yeah. I mean, there's different risk tolerances. There's different risk tolerances for, and like I think the stack ranking, to your point, is like administrative burden stuff. Great, like let's have people maybe do a little scheduling or do a little like HR stuff. Next level, okay, financial processes. Actually, people are kind of open to agents and tech there because there's an ROI value, and they're less of a protected class in the sense of providers, like I was hinting at, have these superpowers of prescribing, of eligibility checking, of clinical data access that is, gifted by virtue of years of training that, like can't be just given to AI and digital tools. Or we are grappling right now on the interoperability front with the implications of that. What could, the abuses that happen microcosmically of somebody overprescribing opioids or someone overprescribing ADHD meds accelerate dramatically when you add zero marginal cost. When you say, we're going to, instead of one doctor in Florida overprescribing, we have a nationwide clinic that's overprescribing. Okay, like that's problems we've seen repeatedly with Cerebral and other, stories. Now you apply AI and you remove any human in the loop, and the friction, the scale is now nationwide or more, and the friction is near zero. Holy shit. Like that is, the implications there are really, really scary. And so that's why the risk profile to me seems to be, you'd think financial is the one that they're least willing to adopt technology towards. I actually think it's the clinical pieces because of the liability and because of the protected nature of the superpowers. But you guys are clinicians, so maybe you tell me.
No, I don't disagree. I mean, if you're stack ranking, without a doubt, clinical workflows is where there's the most resistance. I think, it depends how the risk tolerance of an org and how developed they are in implementing these things as to like where they're willing to take a first shot.
Well, I really appreciate you coming on today and sharing and talking about the, startups, kind of, the future, robots, of course, starting with the clinician. Where do we kind of land? How can we wrap up? Would you guys just kind of parting words, takeaways?
I mean, I'll start with it. I think it's probably the thing that I said 10 times during this is, when implementing a new technology, when starting a company, just work backwards from the stakeholders, the end users, the customers, all of those things to make sure that you're building thoughtfully and implementing thoughtfully.
Next,
I'm happy.
I'll say.
Oh, go ahead, Drew.
Yeah, I think don't be afraid to put boots on the ground, and don't be afraid to really ask those other questions of, hey, why is this going to fail? Like asking that question, because then it'll get down to those workflows that are unique to the company or the clinic that you're selling to. So don't be afraid to go boots on the ground and just ask those why questions.
And Brennan?
Yeah, and if you've done step one and step two that were just listed, and you're saying, "Oh, I need to go integrate," and you're afraid of the scariness. Just remember, we are in healthcare, and healthcare as a vertical is the only vertical that has the superpowers of information blocking, and that is not just some BS regulation. It is something that we are seeing through court cases can be used by point solutions that providers want to use to get connected in one way or another. And it may be difficult, it may be challenging, but at least there's a how that you can't be blocked by the EHR core system of record. That is unique. Nowhere else do we see that. And so the how is available to you, and it is sometimes hard to find, and sometimes you have to push back against the incumbent, this big piece of software. But if you figured out your value proposition, if you've gone and listened to customers, then there's a how available to you, or they are likely in violation of federal law. Holy crap, how empowering is that? Just go solve some problems.
Well, I'm feeling pumped today. I really appreciate you coming on today. This has been a great discussion.
Thanks for having me.
Thanks for having us.
Thanks, Michael.
Awesome.